I'll introduce Dr. Larson to talk about quality.
Great, thank you very much. I hope you all can hear me. So providing high quality care is certainly central to what we do. It's the goal that we have to make sure that our patients get the best care possible. As a health system and as a department, we follow outcomes data, and this guides and informs us on how we're doing. And these elements are not just abstractions. These are all factors that are important to patients, factors such as mortality and complications and unnecessary readmissions. Next slide, please. And looking back over the past couple of years, our metrics have been relatively stable, and this is happening in the face of growth and continued increases in case complexity, but it represents a large opportunity for improvement. We can always do better. Next slide, please. And so there's a lot of great work being done at the level of the divisions, and there's a long history of process and quality improvement at VCU. And to support and augment this, our QAPI group is focusing on several key processes and projects over the next year. Reducing readmissions is as a part of this. It's not just an efficiency problem, but it's a patient care problem also. There's a readmission review project underway on C7 to help provide more insight into the etiology and common factors in the readmission of our patients. We're also coordinating and working with the hospital's readmission efforts to help provide a better continuity of care across the continuum and then post-discharge process. Mortality reduction is certainly a high priority. We are in the process of developing a more comprehensive mortality review process, which will build on the current system that exists within the divisions and at the departmental M&M level. Again, looking for opportunities at the systems and process level to improve the quality of the care that we provide. Complication reduction is a focus of the health system and something that we've been working with the CDI team for the past year and a half with a complication review process. And many of you have helped out with this, and we're very grateful for the effort in looking into these cases to see if there are any opportunities to prevent further issues in the future. And patient experience is a new focus. It's always been a background focus, but now with new data and the help of the Nathan Cunningham and the communications group, we've started to focus on patient experience with a team that's led by Kelly Carter, who's working now in a couple of pilot groups with surgical oncology and acute care surgery to make sure that not only are we providing quality care, but also making the patients feel comfortable and have the best experience possible. So these and other projects in the pipeline, these can all be tools to help improve the quality of the care that we deliver. But they really mean nothing without the input and participation of the people who are providing the care. So over the next year, we'll be asking for your help, and we look forward to working with you and on our journey to continue to improve the quality and safety of the care that we provide. Thank you.
Thanks, Dr. Larson. I'm going to show a short video about access, and then we'll pass it to Dr. Campos to discuss our access priorities. So that video just highlights the current places that we're seeing patients and some of the sites that we're excited about welcoming in 2021. Again, the title, Making It Easier to See Us, because we want our patients to be able to come to us in the community, provide that access so that we can care for them and make sure that we're making it as easy as possible for them to get care here. We'd be remiss without showing some data. So really quickly, have our surgery growth in OR cases and endoscopies. Both of these, we continue to see growth in, obviously FY20 with COVID, with that caveat. Other than that, these cases continue to grow year over year. It's been a 10% growth since 2018. Another area we're going to focus on is new patient conversion to surgery rate. So when we looked at visits from May, June, and July of this year, patients that came in to see us as a new patient, we're converting 40% of those to surgical care. And so again, just a good metric to help us understand when our patients come and see us that we're actually able to intervene and provide the care that they need from a surgical perspective. This is our ambulatory visits, and as Dr. Kasarajan highlighted earlier, our third next available, which just means when the patient calls us, when is the next available appointment we have for them to get in to see us is 4 days. So that's phenomenal for all of the subspecialty services we provide, that we're able to provide that level of access. Dr. Campos?
Hi, good morning. I'm Guilherme Campos. I'm the division chair for pediatric and GI surgery. And as you can see, there have been significant changes, progress, and additions in the past few years at VCU and in our department. Still, this is the beginning of a journey into a new era for all of us and our medical center. We not only have a growing critical mass of people with a shared goal, we also have an expanding clinical footprint and the support from a recently restructured and engaged ambulatory leadership. With that in mind, I think there are two overarching goals when it comes to patient access for the Department of Surgery. One is to become market leaders in all surgical subspecialties. And two, to expand, improve, and facilitate ambulatory clinic and procedural access for patients in need of surgical care. Move the next slide, please. Still, this is an enormous and multifaceted task, but with the right approach, it has been accomplished in other large academic medical centers as ours. Improving and optimizing patient access so the experience is optimal for patients and for providers must include engagement of the entire workforce. You need to help us. While the action items will vary slightly from specialty to specialty, the goals for across all clinic sites are for standard, high quality, and efficient operational process for scheduling, intake, and throughput, with the ability to have technology and systems to measure success and failures, and along the way improve processes. The four central pillars for initial actions plans are the following. One, to maximize providers template. Two, to optimize clinical locations. Then to identify and invest in ambulatory needs to support the mission. And to strategically size on opportunities for growth. However, again, we cannot do this alone. We need everyone to be engaged. And a call to action is that the entire workforce must engage as to be an agent of change. And the department will work with each division to assist in the ambulatory operations improvements. So I will move on into now the each division accomplishments. So again, our division, our primary team has currently 3 surgeons, 1 NP, 1 PA, 2 nurses, 1 dietitian, and 4 administrative people. While I will focus on the clinical operations aspect of the division, we also have a 1-year fellowship, as Dr. Kasarajan mentioned, and a research program that generates about 7 to 10 peer-reviewed publications per year. The main clinical services are these four. We provide minimally invasive and endoscopic treatments for obesity, including primary surgery and revisional surgery, minimally invasive endoscopic procedures for foregut diseases, for primary and revision surgery. I mentioned the revision that a lot of the community sites do not provide revision operations, minimally invasive general surgery, and abdominal wall hernias. Our total volume has actually grown from last year to this year, both the MIS, general surgery, and foregut volume, the bariatric surgical volume, and the endoscopy volume. I just mentioned the last month we did 25 primary bariatric cases. When I arrived here 6 years ago, we were doing 50 bariatric cases a year. So there has been significant improvement in our ability to provide care. Next. However, there is a lot of innovations in the strategic priorities. We are, in collaboration with the Department of Medicine, seeking the establishment of a comprehensive weight loss programs that will house all the medical, surgical, and endoscopic services for the treatment of obesity. This is a major endeavor that is ongoing. We have started the therapeutic endoscopy arm of our program to treat both obesity and foregut diseases. The two main being an endoscopic sleeve gastroplasty, that is basically an endoscopic treatment that allows reduction of the size of the stomach that can provide for outcomes that are quite good compared to other procedures that we have. And we have endoscopic advanced suturing for treatment of complications for foregut diseases and obesity, and we're introducing the transoral fundoplication as one of the options for patients with reflux disease. In collaboration with many other divisions, including the trauma division, we seek to establish an abdominal wall hernia program at VCU to standardize hernia care in our center. Abdominal hernia is a specialty in and itself, and there is a huge opportunity for us to improve the quality and the standardization of what is done in abdominal wall hernia. Dr. Saluzzo is leading now the establishment of our robotic bariatric and hernia surgery program as well. And we are incorporating the ability for surgeons to again do laparoscopic transcystic common bile duct exploration, something that was lost to the GI community about 10 years ago with the introduction of the RCP. But now we have newer technology that allows us to explore the common bile duct in many situations in which endoscopy is not feasible. We seek to maintain our level 1 accreditation with both the college and the MBS QIP, and also as a COE for all payers that we now have accomplished this last year. We want to improve and expand contracting with the major insurers and employers in the region. There are a lot of opportunities in how we can actually reach out to the major employers to facilitate their employers to seek care in our division. And we're looking to expand our clinical locations and improve the efficiencies in our clinic as well. I want to hand over to Michael Butans, that's the Chief of Trauma and a great colleague.
Thank you for the opportunity and the privilege to be part of this incredible team. So we're at Acute Care Surgical Services. Our services are composed of both clinical services and non-clinical programs. Our clinical services are provided by W-boarded acute care surgeons in trauma, emergency general surgery, and surgical critical care, and now wound care and ostomy care, and really providing the top-notch care in the Commonwealth, if not in the entire nation. Equally, we have our non-clinical programs, which are truly now nation renowned in terms of our injury and violence prevention program, our Center for Trauma and Critical Care Education program, and our International Trauma System Development and Research program within the Global Surgery program. We are one of the busiest division in the department, as you could see in our numbers and the key volumes below, including our trauma team admissions more than 4,000. To put it in perspective, to be a level 1 trauma center, you need 1,200, and our numbers are more than 4,000, just to put it in perspective. Next slide. Again, a short video. So sorry, there was no volume that I could hear from the video, but I will just to quickly mention, when your life is turned upside down, you need access to the best emergency and trauma care anywhere with the highest quality. And that could happen to any of us at any time. And this is what we have been providing, and we are committed to provide for the past 40 years of excellence and leadership. We're the first level 1 trauma center in Virginia, the second in the nation. We're the Center for Trauma Care Education and have launched the first university-affiliated accredited paramedic programs. We teach more than 40, almost 50% of the pre-hospital providers in the entire Commonwealth, just to see our impact. We also just became the statewide technical assistance center in the nation for hospital-based community violence prevention. And we continue to be both state and American College of Surgery level 1 trauma center designated and verified. And we've been through it already 5 times, and we'll keep on going through it. Our mortality rate is 50% lower than the national average compared to more than 500 other level 1 trauma centers. Our complication rate are lower in every aspect of care when it comes to emergency trauma care. So this is really what success looks like in the healthcare industry and for the citizens of the Commonwealth. So our key focus is to continue to expand our regional trauma network and to establish a comprehensive emergency surgery and acute care strategy for the health system. Those are our main drives for the upcoming year. And now I have the privilege to introduce my colleague, Dr. Benjamin Medallion, who's the chair of the cardiothoracic surgery program.
Good morning. So I'm Benjamin Medallion, recently joined as the chair of cardiothoracic surgery and actually arrived with all the uncertainty of the pandemic in March, when really nobody knew how to deal and what to do. And I was pretty overwhelmed to see how soon after this mature system really was able to develop a new normal and basically regain new normal activity. And I think this is translated to those numbers. Yes, we are down a little bit compared to previous year, but almost the same number. To me, it looks like a success in view of everything we went through. I think what I did find with the division is a great team that really collaborate, mature, and very trying to do the best and doing the best. And I think everything is summarized in this short clip, if you can rerun it again, because you can wonder, so what's so unique about a patient walking in the hallway carrying it's kind of a trolley? Well, there's a lot of it, and it does not go without saying. This patient was transferred to VCU from an outside facility in a late, after his heart was completely distracted with the myocarditis beyond repair, and it was clear that he is about to die unless he will undergo most likely a heart transplant. But he was too sick to undergo heart transplant at the time. He had multi-organ failure. And you see him over here after he received a surgically implanted mechanical circulatory support that supported him to regain and recover and to be strong enough to undergo 6 weeks later a heart transplant successfully, and now is recovering at home. And walking like that in the hallway with this device is not happening in too many places in the States or even elsewhere in the world. And that's unique. And without the support of all this team, whether it is surgeon, cardiologist, heart failure, nurse practitioner, nurses, PTOT, I mean, it was a respiratory therapist, everybody really. I mean, I was overwhelmed to see the enthusiasm and the willingness to help in this institute, and that's really translate to what we do on a daily basis. So, and our short vision and long vision, we still have a way to go. We do need to expand, and we're working on it, and we soon are about to open new clinics in the neighborhood of Richmond, in Williamsburg, Fredericksburg, and Tappahannock. We are working on expanding our cardiac and thoracic block time in the operating room. And we basically really deliver all the variety of cardiac and thoracic surgical services that can be delivered, and focusing on subspecialization in the currently and already in the near future, whether it is comprehensive aortic center with vascular. Our lung transplant program is about to be restarted, and it's in the final stages in the state level. In the thoracic side, there's a comprehensive thoracic and esophageal program, we're about to expand our community collaboration with cardiac surgery, cardiothoracic surgery in Riverside Health System, and to help them to improve and deliver better care in this area. We hope later on to establish a shock response team in addition to our Center of Excellence of ECMO that we are delivering. So a lot of work, some is already being done, and all this is being done with an amazing quality, I think, which we are striving to get even better in all those measurement and benchmark we are having. We would like to climb in the USA News Top 50, which are already number 45 and number 5 in heart in the state, which I think is a great achievement. Working on expanding basic and translational and clinical research, and we have several new faculties, with some are PhDs that probably will deliver these goals in the near future. Hoping to attract more fellows by trying to move from our standard or classic fellowship program to the integrated cardiothoracic residency, which means that fellows will no longer need to be board certified in surgery in order to be fellows in cardiac surgery, but will start from day one in cardiothoracic surgery, and hoping to establish PA and perfusion training program. So a lot of vision and work, and but happy to be part of this great team.